treating a single patient relies entirely on clinical knowledge. Treating 10,000 requires logistics, economics, and systems engineering. When you scale healthcare delivery across an entire population, individual medical intuition fails. Averting a system collapse requires shifting from reactive, case-by-case treatment to proactive, mathematical planning. Public health administrators manage this scale using a formalized, cyclical system. This framework is designed to take finite resources and map them directly to overwhelming community problems. This flowchart illustrates the planning cycle. First, analyze the health situation, set specific objectives, and assess available resources. Next, formulate the plan, implement it, and conduct evaluation. Finally, the evaluation data feeds directly back into the initial analysis, creating a continuous, adaptive living system. Medical students often try to memorize discrete management frameworks in isolation. That approach fails on exams and in practice. Every framework you learn maps directly to a specific node on this cycle. Without a structured, iterative planning cycle, public health interventions collapse under their own scale. Resources drain into the wrong communities, and target diseases spread unchecked. All population-level objectives must be mathematically precise. A vague intention gives administrators no baseline to measure failure or success. This diagram breaks down the SMART criteria: specific, measurable, achievable, relevant, and time-bound. Reduce malaria is useless. A SMART goal dictates reducing falciparum incidents from 15 to 5 per thousand in a district by December. Once that target is established, the required tasks must be scheduled concurrently. Historically, administrators mapped these workflows using Gantt charts. This horizontal bar chart plots independent activities against a rigid timeline. You can visualize staff training overlapping with vaccine procurement. But Gantt charts have a flaw. If a shipment is delayed, the chart cannot calculate how that forces a cascading failure across dependent tasks. Horizontal time tracking is insufficient for the complexities of modern medicine. To identify sequential bottlenecks before they occur, administrators rely on network analysis. Network analysis treats time as an engineering problem, connecting dependent variables to calculate exact constraints. In 1958, the U.S. Navy had to coordinate thousands of contractors to build the Polaris missile system. Because the technology was novel, the timeline for completing tasks was completely uncertain. They engineered the Program Evaluation and Review Technique, or PERT. This formula calculates expected time using probabilistic math. It weighs 3 distinct estimates: the optimistic best-case scenario, the pessimistic worst-case, and a heavily weighted most likely scenario, giving administrators a reliable timeline despite total uncertainty. By contrast, routine medical logistics, like an annual flu campaign, do not have uncertain timelines. For well-defined, deterministic projects, administrators use the critical path method, or CPM. This network map displays the critical path, the absolute longest continuous time path moving through a project. It presents a paradox. This longest sequential chain dictates the absolute shortest possible project duration. Delay one step, and the entire campaign fails. The frameworks serve entirely different functions. PERT optimizes for managing time uncertainty. CPM assumes time is certain and optimizes for cost-time trade-offs, allowing administrators to spend money to accelerate or crash specific steps. For examinations, the critical distinction is orientation. PERT focuses on hitting milestones, making it event-oriented. CPM focuses on executing individual tasks, making it activity-oriented. In practice, health administrators deploy PERT to combat novel viral outbreaks, where parameters are unknown, and they deploy CPM to execute routine mass vaccinations. After securing the timeline, administrators must optimize physical constraints. A hospital pharmacy holds thousands of distinct items, and mismanaging them carries lethal consequences. ABC analysis attempts to control inventory strictly by capital. It categorizes items entirely by their annual consumption value, ignoring their clinical use entirely. A items make up roughly 10% of a hospital's stock, but consume 70% of the budget. They require continuous administrative monitoring, while bulk C items like cotton swabs are managed casually. The alternative is VED analysis. VED ignores cost entirely, categorizing items strictly by their clinical impact. Are they vital to survival, essential, or merely desirable? This creates an immediate administrative dilemma for hospitals. Epinephrine is cheap, placing it in Class C, but its absence kills patients instantly. A specialized multivitamin might be expensive, an A-class drain on the budget, but clinically it is only desirable. This 3x3 matrix cross-references economic cost against clinical criticality, creating the ABCVED model. Triage relies on this grid. Category 1 items require direct oversight as a chief medical officer, while Category 3 items are delegated to lower-level staff. Managing a pharmacy strictly by cost risks patient lives, while managing strictly by clinical need bankrupts the hospital. The matrix solves both. Physical inventory relies on matrices, but managing human capital relies on strict procedural boundaries, specifically the difference between supervision and delegation. The concept of delegation is highly specific. It is the transfer of responsibility and the necessary authority to a subordinate to accomplish a distinct task. This organizational chart illustrates the core axiom of medical administration. A leader can assign responsibility and grant authority downward, but they can never delegate accountability. The manager remains totally answerable for the outcome. In 1954, Peter Drucker formalized how to ensure those outcomes are met through management by objectives. Under MBO, managers and employees do not act unilaterally. They jointly negotiate and set specific goals. This creates parity, ensuring the subordinate actually has enough authority to deliver the expected results. Without structural delegation, a single medical director is limited by their own physical bandwidth. With it, they can command a sprawling public health workforce without losing operational control. A plan built with tight matrices and delegated authority means nothing if you cannot mathematically prove the intervention worked. This process absolutely requires continuous feedback loops. Monitoring is the act of continuous, real-time data collection. It is executed while the program is actively running, allowing administrators to spot bottlenecks and course-correct immediately. Program evaluation occupies an entirely distinct analytical space. It is episodic, occurring at the midpoint or at the very end of a campaign, designed to judge the relevance, efficiency, and final impact of the entire project. To gather this data, governments rely on a health management information system. An HMIS processes massive amounts of raw clinical data and converts it into the exact metrics required for high-level administrative decisions. Those decisions ultimately come down to health economics. When judging a program's value, administrators can use cost-benefit analysis. CBA takes the cost of the program and the resulting human outcomes and measures both purely in monetary terms. CBA allows a government to compare building a hospital against building a highway because the output is a simple dollar ratio. But it carries a flaw. It forces administrators to assign a strict monetary value to a human life. This scale compares CBA to the medical alternative, cost-effectiveness analysis. In CEA, the costs are still calculated in currency, but the benefits are calculated in natural health units, like lives saved. Using CEA, an administrator calculates the exact amount of capital required to avert a single disability-adjusted life year, without having to price out the value of that year in dollars. Administrative constraints force the economic quantification of human life. By relying on natural health metrics instead of currency, CEA provides a more ethical rationing tool. When studying these frameworks for an exam, they often appear as disconnected theories. They are not. This flowchart represents a unified system architecture. Every tool we discussed executes a specific node. SMART criteria map to setting objectives. ABC VED maps to assessment of resources. Gantt, PERT, and CPM provide the framework for formulating the plan. Finally, cost-effective analysis executes monitoring and evaluation. In India, eradicating polio required coordinating millions of doses, thousands of transit teams, and real-time surveillance across a subcontinent. While immunology provided the vaccine, actual eradication of polio required PERT network analysis to route supplies, HMIS tracking to verify coverage, and strict delegation to deploy field workers. Mastering health planning and management ensures that clinical expertise is never wasted by logistical failure.